Hey everybody, this is What's Up Mike, and yeah, this is the World War II for healthcare workers right now. I'm very impressed with the way the United States and healthcare, the industry across the country is flexed right now. What people are doing, the preparation and setup, how people are responding now, but I've got some maybe controversial opinions on those that might say this isn't what I signed up for in the healthcare industry. So, yeah, it's interesting to see the news and watch all of these reports come in about how things are, I don't know, different preparation for the virus and massive numbers of patients who need care showing up at hospitals already, especially in New York City, and then soon in many other communities. Right, like uh, I'm in Charleston, South Carolina, and my wife works at the main trauma center here in the city, the the main critical care hospital here in Charleston, and they have patients coming in, plenty of positive tests. They have plenty of employees that have tested positive, and so there's that. Like it's an active situation. It's not like it's not here yet, but because it is, but it's not at risk of overwhelming any healthcare systems here. Whereas in New York City, there's real risk of overwhelming healthcare systems. An article I read recently suggested that the peak numbers of ventilators needed at one time. So as like ventilators needed, this graph goes up, and the peak number of ventilators required at one time to manage the patient load that's predicted is something like 30,000 ventilators in New York City, and there are 5,000 ventilators in New York City, something like that. So they're facing a rough situation, which um, I mean, they've set up hundreds of beds in field hospitals in Central Park. There are makeshift morgues on the street with refrigerated shipping containers. Um, but what that is that's a testament to a healthcare system that is prepared, and a healthcare system with people working in it who are prepared and willing to flex that way and to make those adjustments in order to support increased capacity and manage the patient load. One of the biggest concerns is medical rationing, because when you have significantly more patients in need than you have equipment to support, this is something that we have not on a broad scale seen in the medical industry in the United States uh, on U.S. soil since the Spanish flu in 1918. So it's uh, it's a scary thing, and it's not something that we're used to in American culture, because so much of culture in the United States in industries is based on hierarchies, right? If you have private insurance or great health insurance through your company, through your place of work, versus lower quality insurance plans, if you're affluent and have access to, private services or something like MDVIP, these services where uh, doctors, it costs more, but doctors take on a smaller patient load so they can be more engaged with each patient. There's all these tiers and hierarchies within the medical system, and people are used to receiving their level of care in whatever hierarchy they're in. It's almost like a caste system in healthcare in the United States. But what rationing is rationing disregards all of that system, all of those hierarchies, all of the, uh, someone's ability to cover services financially because of scarce resources. So, um, essentially, what that means, what it boils down to, is potentially withholding beneficial treatments from people who are sick and require the treatment. Let's focus on ventilators with this case. So, withholding a ventilator from someone who needs it, who must have that ventilator uh, to support their recovery, or who must have that ventilator to live, and giving it to someone else knowing that that patient is going to die because there's not enough ventilators. So that's what medical rationing is. And the ethics around medical rationing is, man, it's complicated stuff, and it's that burden is placed on individual care providers in many cases. There are ethical policies that are put out across organizations. Hospitals, especially big ones, teaching hospitals, have um, people whose job it is to manage the ethics of medical decisions, right? Uh, and they're putting out policies that focus on, uh, fair allocation, whether rationing those kinds of treatments, care, use of equipment like ventilators, to those at near end of life, or to those with a worse outlook, to those who are particularly more elderly. Um, there are serious concerns around like that decision making process. Who gets the ventilator? And you can get into that much more in a much more complex way when you start to ask questions about, well, if we have a young, seemingly robust patient who's 40, who has 3 kids, who he or she supports entirely with their income, who needs a ventilator, right? And then you also have a 65-year-old ICU physician who's single, who doesn't have a family, who's older, who has fewer years left to live, but is the kind of person whose profession contributes directly to saving more lives, right? So you err on the side of like this tier of decision making when it comes to medical ethics in rationing of needed treatment and equipment. It starts with physiology and expected outcomes, right? So it starts with likelihood of recovery. That's this first step in the decision making process of who gets the equipment, who gets the treatment. And from there it goes down a list, basically, right? So the what that list entails, the specific steps. So so it starts with physiology, likelihood of recovery, and then all of those being equal among people whose physiology and likelihood of recovery is equal, you start to step down to the next requirement, or the next decision-making criteria, which it starts to get a little bit gray there, right? Because then you start to look at potential quality of life after recovery, years left to live, all sorts of other decision-making criteria that gets very, very subjective. So you start looking at these greater good, obviously number of lives saved. That's just culturally, that's going to be the leading criteria for decision making and the thing that's most supported, right? So if patients can participate in decision making, that's a huge thing, right? Many patients will make their own decisions that actually opt out of some of that treatment, but you can't obviously that's going to be more the exception than the rule. So, it starts to get into extremely difficult decision making for medical professionals at a point where they don't have a lot of time and there's so many requirements on their mental health, so many professional requirements on not just their time but on their decision making and cognition. I mean, these healthcare professionals are being massively overloaded with patients, with cases, with requirements, and they're having to make these decisions subjectively based on the ethics of the guidance on ethics. Their own, in many cases, their own personal ethics have to play a part in this. Have to, right? And so these ethics boards at these hospitals are writing guidelines, and doctors, healthcare providers are going to have to, or trying to, or attempting to follow these guidelines and make the best ethical decisions. But medical rationing gets weird for people, especially those who are affluent and used to leveraging that for care, right? I mean, a celebrity who's very rich may be laying in a field hospital because you don't get to buy your way through medical rationing. Someone who's very, very rich has plenty of success, has plenty of funding, may be denied a ventilator. And that's not something that we're used to in American culture. We're used to, maybe unfortunately, these hierarchies. We're used to standards of care that are directly related, directly proportioned to income. And so that's changing right now. So I read an amazing article in The Atlantic. I've got it pulled up, and they're talking about the decision trees guided by 4 basic principles of medical ethics. So personal autonomy, beneficence, non-maleficence, which is do no harm, and justice. So, a patient's personal autonomy, what they start with there is that patient's decision making. But that's the first thing that gets limited, right? Someone needs a ventilator. They say, I want a ventilator. I want this care. You move to the next step of, is the care available? Usually in normal healthcare operations, you never have to take that second step. For decades in America, we haven't had to take that second step of, is the care available? So this is a very unfamiliar question for healthcare professionals to have to ask themselves. It's a very unfamiliar question or conversation for healthcare professionals to have to. It's an unconventional, uncomfortable conversation to have with patients. I mean, uncomfortable conversations happen across the board in healthcare, but really, look to transplants in healthcare, right? This is an area where providers within transplant specialties are extremely familiar with rationing. They ration every hour of every day because there's never enough organs. People die without getting an organ transplant that they need every day in every American city. So people there, this is an interesting place to look when it comes to rationing and how the decisions are made. The first thing these healthcare professionals have to commit to is not discriminating, right? But at some level in the decision, you have to start discriminating. So you begin without discriminating. You don't take an ageist approach, despite the conditions around this virus. This virus is very ageist. So, you can't discriminate initially until you've defined that physiology. And so going and looking at what medical ethicists, is that a word? Ethicist? I think so. You have to start by having public support for this rationing somehow, right? Like the whole society has to buy into the process, or you get chaos. I think we've got a pretty solid structure system. You bring in law enforcement and other things, and we have the ability to control our situation as a society in the United States. But other places that are a little more lawless, maybe not. Little less infrastructure, maybe not. But you have to start with the perspective of, we're not just going to withhold care from elderly and disabled or chronically ill people. Because if you begin there, you remove an incredibly important principle in all of this, which is each patient needs to have their own hope when seeking healthcare. Because if an entire class of patients just doesn't get to have any hope for recovery, if you say we're not giving ventilators, we're not giving treatment with a ventilator to anyone over the age of 80, you can't do that. Because when you remove hope before you start that conversation, you start to descend into chaos, and you get significant protest from the patient population and everyone around them that's being, from the get-go, excluded from treatment opportunity. So you start by getting public support for rationing, by saying that everybody has an opportunity for care. So you can't have those hard and fast, those explicit age boundaries, those explicit um, previously existing condition boundaries. Um, and then you move on to making what you hope are the most just decisions, right? So when you as people come into care and as healthcare systems hit max capacities, um, you have to start discriminating, right? So starting with physiology, all other things being equal, if you have a very, very sick 70-year-old and a very, very sick 20-year-old, all other things equal, in this case with this virus, the 20-year-old not only has a higher likelihood of survival if put on a ventilator, but also has a higher likelihood of long-term contribution and quality of life. And these are things that have to be taken into account. So, you know, thankfully, from our cultural perspective, Americans pretty much universally want to see kids treated first. That is not the case everywhere in the world, believe it or not. I mean, most people in America have never even been someplace where the culture, the society around this, doesn't put kids first. But that, I mean, I have. Go to Afghanistan. Watch family meals in rural Afghanistan um, where there isn't food planned for the children. Where if the kids eat, it's because they had some moxie and got in there when there was still food left on the table. Adults eat first there. It's just, I mean, you can have more kids, but if the patriarch of the family and the adults in the family can't farm the fields, there's no food for anybody. So these different cultural situations, these different life requirements on how you put food on the table might dictate a culture where it is not kids treated first. But that's the case in America, where we want kids first, and that's pretty universal. So there's lots of different decisions and cultural factors that go into medical rationing as well. You know, I think there's going to be serious outcry when it comes to wealthy and powerful people coming up on the unfortunate side of medical rationing, because wealthy and powerful people can get loud. They have access to media, so it'll be very interesting to see how that plays out. So, yeah, it's gonna get very weird with that. This points of discrimination in medical rationing: age, mental illness, economic contribution. Does a business owner get, and with all other things being equal, does a business owner get preference over someone who stocks shelves? I don't know that that's fair. You know, is it a medical professional's responsibility to do actuary level analysis on a theoretical idea like someone's possible lifelong market contribution or societal contribution? I don't know. It's weird. So, yeah, medical rationing, medical ethics. I think this is something that it's worth bringing someone on, maybe, or expanding this conversation. It's very relevant, and it's something that most people in America are completely unfamiliar with, save a few sections of healthcare, like organ transplant. So something else that's driving me crazy, and I won't spend too much time on this second point because it's controversial and it's gonna touch on some feelings of people who aren't doing this. So let's be clear: 99.99, not whatever percent of healthcare is stepping up, flexing to support, and going above and beyond the job descriptions under which they were hired. Right, but I have seen a bit, and this is inevitable, and I come from a place where this is more likely and we've got more experience with this, people that are in healthcare and saying, this isn't what I signed up for. I've got a background in military service, and so this reminds me, this is a very familiar feeling to a military population as a country goes to war. So someone who enlists in the military or is commissioned as an officer in the military in a peacetime army, Navy, we'll say Army. In a peacetime army, you enlist, and then the military goes to war. And the conditions under which you began employment change, and you're now under, in the military's case, obligated employment and service for a situation that is different than the conditions under which you signed up. So the issue with that is that assuming those conditions would never come to pass is both short-sighted, or it's short-sighted. It lacks maturity and individual responsibility, and there's no place for it. There's no place for it at all. Not in healthcare, not in the military, not in any industry where you perform such a necessary function that the very structure of society depends on it. Law enforcement, first responders, these kinds of direct societal stability and life support jobs, when you sign up to work there, many of them come with a premium on pay. Many of them don't, though. You sign up for the eventualities, all of which could come to pass within that industry. So I have no time for someone who says this isn't what I signed up for and complains. I get complaint. Infantrymen complain on a level of expertise and frequency nearly unmatched. But when it comes down to it, you have to execute. So while I'm wildly impressed and proud of the American healthcare industry response, for those individuals that might say, this isn't what I signed up for, or this isn't my job, the only message I have is get out, quit, never work in healthcare again because you're not made for it. It's got no place. In my mind, it's an unethical standpoint. You signed up for this industry, you step up when called upon. It's a moral imperative. So, to those who might say, this isn't what I signed up for, or to those that would complain excessively outside of personal circles, outside of venting, you got to vent. Mental health is a premium these days, especially in industries like healthcare. But I have no place. I have no patience for those who would not answer the call when that's their chosen profession. So, yeah, that was something that was a little frustrating to read about and disconcerting. But thankfully, with heavy caveat on that the vast majority of healthcare workers have stepped up in a heroic way and are preparing to. So, yeah, crazy times, but that's what there is to talk about at home, quarantined. I made my once every 2 weeks grocery run today, which, family with 6 people in the house, only getting groceries every 2 weeks means you are slam full. Lucky if you can fit it in one cart. And that's more commonplace these days, really, really full carts in the grocery store, people trying to space out trips. I get it, but damn if I'm not getting judgy eyes still with a full cart. I didn't even have toilet paper in my cart. I have not gone to a store and bought and had more than one pack of any kind of, scarce items these days in my cart. But man, the judgy eyes come quick. Anyway. Yeah. Hey. Thanks for listening in a little bit. These episodes are actually getting a little bit longer. I don't know if that's a good sign or not, but yeah. Yeah, stay well out there and support and be impressed with the healthcare industry. And yeah, we'll see you again soon.